been kind enough to join me for this discussion. Some of this will be basic information. Some will be a little bit more advanced. I encourage any and all questions from anyone out there who is interested in superficial vein disease. I'll also be talking today a little bit about a few other things that relate to vascular diseases. So it's not just going to be varicose veins and superficial vein disease. We'll be talking a little bit about iliac compression syndrome, or May-Thurner, and then also about peripheral arterial disease as well, just so that we just kind of mix it up a little bit. But the main thrust of this discussion today will be on varicose vein disease. So let's get started here. So we're going to talk a little bit about what are varicose veins, what causes them, a little bit also about, in general, superficial vein disease, some about chronic ulcers, which is really the most advanced form of superficial vein disease or varicose vein disease, a little bit about treatments, and as I said, I'm going to mix in maybe a couple peripheral arterial disease cases in here, and then finally we're going to talk about our ability to see people via telemedicine, and then answer questions. And as I said, if anyone has any questions during the presentation, I certainly don't mind being interrupted, and so it's a little bit more didactic and less just me speaking into a camera here. So let's begin. This is me, very, very important part of this presentation, but the only thing to mention is I am an interventional radiologist, which means that my practice is focused on image-guided surgeries. That means that I use ultrasounds, x-rays, CAT scans, etc., to perform what used to be done surgically. So it's really the most, in my opinion, cutting-edge area in medicine, and one of the most unique fields, and something I really love and I believe is really an amazing field that's pushing medicine forward. And that's we're able to really cover all kinds of vascular diseases. Now, first off, let's talk about what varicose veins are, okay? So people see them, and the more you learn about it, the more you'll see other people. We see that there are healthy veins and there are varicose veins. Now, one thing that's very important for the layperson to understand and not use sort of similar to each other is that there are arteries, and they basically typically bring blood from the heart to the rest of the body, and the veins return the blood. And that's important because arteries have a heart, and I mean the heart pumps the blood around, so there's a lot of pressure, there's a velocity, but once that blood reaches, in this case, say your feet, they have to turn around, the blood has to turn around and come back up to your heart. Therein lies part of the problem here, because you know, there's an issue that there is no heart in the lower extremities. So because there's no heart in the lower extremities, then, you know, how's the blood going to get back up? So basically, the calf acts as the heart of the lower extremity, and every time your calf squeezes, blood goes up to the heart. Now, of course, we know that gravity is always pulling down on us, and so gravity is also pulling down on blood. Thus, the body has a very elegant system of valves, and we can see the valves. I guess it doesn't allow me to do that. I was hoping it would. But in any case, you can see the valves in here in the vein. And then what happens to people who develop varicose veins basically is that the valves break, and thus instead of the blood just going in one direction, like getting caught on this trapdoor, the blood goes up and comes back down. So according to the American Society of Vascular Surgery, there's at least 20 to 25 million Americans who suffer from varicose veins. Personally, I believe the number is an underestimate. There's many more than that. It's an extremely prevalent disease, and there's really a whole variety of people who have this disease, some with just little spider veins or telangiectasias, others who have varicose veins, the big ropey veins we see, and then others who have more severe symptoms like swelling, the brownish color, otherwise known as hyperpigmentation, and then it goes so far as to developing chronic venous ulcers. So I think it's really more prevalent than we see. Now, what are the causes of varicose veins? Really, the main root cause is poorly functioning valves in the vein. Now, why does that happen? It's really a little unclear, but what we do know is that these things that we see below are real causative risk factors. So things like pregnancy, certainly women are more prevalent with the disease as we get older, aging. people who sit and stand a lot. So we see a lot of people who have careers that involve standing, teachers, hairdressers, waiters, waitresses, etc. A lot of standing, and that leads to vein disease. And genetics really does have a big role in it. I mean, we have many patients who will say, my entire family has vein disease, my mom, my sister, everybody. And in fact, I've treated many families where they send in somebody as, I guess, the test subject. They get their veins treated, and then they say, wow, well, these treatments aren't so bad, and now look, I feel so much better, and they send in the rest of their family. So it's clearly a genetic predisposition to developing this disease. Certainly obesity also has a role as well. Now, again, what causes it? Now, we refer to it as venous insufficiency or failure of the valves. And as I was showing earlier, we have these valves that are really elegantly deployed or in the body, and particularly in the superficial veins. So using the greater saphenous vein, which is probably the most significant superficial vein of the legs, it runs from your inner ankle up to your groin. There are between 10 and 20 valves in that vein. Now they're supposed to function like this. The blood's supposed to come up, and then that's during muscular contraction. So the muscle squeezes on the vein, and it kind of squeezes this way. It shoots the blood up, and then the valves are supposed to prevent the blood from dropping back down. People who develop venous insufficiency, the valves don't work well, and then the blood then goes back and forth, which is why we refer to it also as reflux. So once the valves become incompetent, the blood goes back and forth, it refluxes, and then the body has to deal with that somehow. And initially it's with small spider veins, then with bulging out varicose veins. Subsequently, it leads to edema or fluid in the legs as the disease progresses. Then it leads to the pigmentation or the browning color. Again, that's related to the deposition of iron, or red blood cells have hemoglobin, they have iron, that causes rusting or a brown color in your leg. And finally, the most severe form, which is chronic venous stasis ulcers. So you can see that there's a natural progression, and we grade people based upon that. So, let's talk a bit about the signs and symptoms. So the most common symptoms that we see are actually people complaining of aching and throbbing. So they may say, after I stand on my feet for a long period of time, my legs feel heavy or they ache. Sometimes they can point to a specific vein in their leg and say, this one really throbs and burns and aches. Some people may feel some weakness, again, fatigue in their legs at the end of the day. Other people have itchiness or a dry skin when the disease progresses. And if we go back here, I meant to go back. We also occasionally see people, as I said, with swelling of the legs and ankles. And then sometimes people will tell me that they have severe leg cramps. Now, we've all had a leg cramp here or there in the middle of the night. It's very, very painful. If you've ever been woken up with one, I can say I personally have. Very painful. Unfortunately, some people suffer from them almost daily or several times a week. You can imagine how debilitating that is. And believe it or not, the varicose veins are a causative agent for that. And so the good thing is if you have that symptom and you have vein disease, I can pretty much tell you you're going to have significant relief in your symptoms when you get treated. Now let's talk a little bit about other vascular diseases. And so this picture is not for the faint of heart, and I won't leave it up forever, but you can see this person has a pretty bad ulceration in their inner ankle, very common location for these, for various reasons, including the fact that there's perforators here, which are a different type of vein. And you can see that after treatment with ablation and treatment of the perforator, you can see the remarkable improvement in this person's leg. So this is treatable, but this is really the most severe form of the disease. And the truth is left untreated, if people have varicose veins, especially at a relatively young age, over time, left untreated, it can certainly progress to this. And I've seen plenty of people with this disease. For example, these are several patients, and this is one patient of mine, there's another one, but this lady had suffered from superficial vein disease for a long time. She'd had all kinds of treatments 20 years earlier, but eventually, when she came to me, she had this ulceration. You could see how really painful, imagine how painful that was on her calf. And she had a year's worth of attempted treatments by multiple other doctors, including all kinds of wound care, including hyperbaric oxygen. And yet what they didn't do is really do a deep dive into her superficial venous system. And once we did, we discovered that there were, in fact, superficial veins causing this. And after treatment, you can see how well this thing healed up. And it's hard to really tell you how grateful this person was, because she had suffered for so long with constant pain. So, it was certainly very satisfying for me and satisfying for her to be able to get rid of that. And then on the other side of the screen here, we see a similar case here where there's another, erosion in the skin. There's some dermatitis. And while the skin isn't perfect, okay, the ulcer is healed. And when the ulcer heals, typically the pain goes away. These patients typically are so grateful that you've managed to fix that. So, it can get that bad. This is considered stage 6 of superficial vein disease. Now, here's yet another case, someone again with several of the signs of severe disease. You're looking at hyperpigmentation. This is the browning color here. You're looking at various elements of dermatitis, and then there's a sort of a weeping appearance of this leg. This person had insufficiency in their they also had edema. This person had insufficiency in their greater saphenous vein, as well as perforator, or maybe more than one in the vicinity. And then after treatment, you can see how, again, although the skin isn't perfect, all this, weeping and the various ulcerations have healed up. Again, these are people who are really desperate for help, and when you can help them, and we can help them, it is very, very rewarding, and the patients are thrilled with the outcome. Now, sometimes the patients who have really severe disease have something called May-Thurner syndrome. And May-Thurner, this was back when you can name things after yourself. I always wanted to have a Shiloh syndrome, but it's too late for that. So May-Thurner were 2 doctors who anatomically delineated this particular problem, and that is that the left common iliac vein sits behind the right common iliac artery. We are all built this way. So imagine everybody has an aorta, one blood vessel that goes from the heart down to the legs. It has to split or bifurcate into 2, like a pair of pants. And unfortunately, the way we're anatomically built, the veins coming back up from the legs also have to form one vein called the inferior vena cava. And the way we're all anatomically built is that the left iliac vein sits behind here. And that's the way it is. Now, in some people, the space there is too tight, and thus the artery can compress the vein shut, acting like a vise on the vein. For example, this is a demonstration of that situation. And here we see somebody who had extreme narrowing here. It's much worse than this venogram even lets on, because what we see here, this is a venogram, which is where we stick a catheter in a vein in the groin. Here's a common femoral vein. We inject dye. It runs up into the inferior vena cava. It demonstrates this. And you might say, well, that's not so bad. Well, we also have this modern technology called IVUS, and in IVUS it stands for intravascular ultrasound. This is the device, this little white circle, and the green over here is how tight the vein is right here. After stenting, which is what we put in here, an 18mm wall stent, you can see how the internal scaffolding or the stenting has helped to keep this open. And now all these extra veins, which are called collaterals, or some that go across the pelvis here, and these additional veins, they're all gone, which now means that this vein, which was narrowed down to almost nothing, like a 4-lane highway narrowed down to 1, is now wide open. And as a testament to that, you can see the IVUS at the same level, showing now how wide open the vein is, where it was this narrow before. Okay, this here is the actual artery compressing it, and here you see how the artery gets kind of pushed out of the way. So again, this is something I also treat, which is not an uncommon condition, particularly in people who have just one leg affected, their left leg, and it's something that we look for in certain situations, and it's certainly another thing that can be really amazing to treat and very rewarding for those patients who have it. So let's talk a little bit real quick about peripheral arterial disease. It's sort of a cousin of vein disease. We obviously, diabetes is a big problem in the United States, and the International Diabetes Foundation estimates that about every 20 seconds someone loses a limb, and at least half of those patients have not had any real evaluation prior to amputation. That's really, really, really not right. It's tremendous shame that anyone would allow themselves or their family member to have an amputation without having proper evaluation of the potential to have the flow to their leg improved. Okay, and it's not as hard as it seems. And really, if you or someone you know has a situation where you are involved in this, really you have to seek out a vascular expert who's capable of helping you out with your chronic limb ischemia problems. So here's an example of a case from several years ago. This was actually an 85-year-old gentleman who had 2 prior attempts at this. And basically, he was a very active gentleman who just wanted to be able to walk, and he couldn't. And you can see why. This is the artery. Okay, you can see after it was repaired what it should look like, and you can see there's this giant gap here. It's missing. So that's the equivalent of shutting down a highway completely. So if you shut down your major highway, in my area it's I-95, well, people are going to start taking side roads. You know, they're going to get off before the accident or before the construction, and they're going to try to work their way around the side streets and eventually come back. Well, we all know that you can do 65 or 70 miles an hour down the highway. So similarly, blood is traveling quickly. And here, when this is blocked, you're on a side road where there's 25 miles an hour or 30. So you can imagine how even though it's amazing that the body's able to sort of work its way around here, it still is extremely debilitating. In this case, it's causing something called claudication. The person cannot walk very far without experiencing severe pain, and using complex interventional techniques, in this case, including accessing from above and then from below, we were able to finally reopen this and put a stent in here, and he's been living pain-free and enjoying his life since. Another similar case is a 50-year-old diabetic patient who complained again of tremendous pain in his buttocks, his butt, and his legs. And you can kind of see why now, maybe based on the last picture. You can see there's blood on this. Is when you're looking at x-rays, this is actually the left. This person's facing you. So this is the left leg. This is the right. Something's missing here, right? So what's missing is the artery. There's no flow. And so you can imagine when he walks or does anything, you're not getting any flow down here. So it has to come down this side, which is also diseased, and somehow find its way across through these tiny little vessels. So again, through some complex techniques, including accessing one side, accessing the other side, and doing what we refer to as a chronic total occlusion recanalization, was able to reopen this artery and put in what are known as kissing stents. They're stents that basically, you know, kiss each other in the aorta. So you know, the reality is that this can be done. This actually can be performed as an outpatient, and again, is a tremendous way to help people who are oftentimes very desperate for help. Finally, another last case is a gentleman also with a diabetic ulcer on their foot, and you can see here again there's like a little thread, almost nothing getting through, and there's also very poor flow here below the knee. And without really going into too much detail, so in the interest of time, was able to reopen this using techniques called atherectomy, angioplasty, and stent. We're burrowing a hole through the artery, then ballooning it and putting in a stent in. You can see the tremendous improvement, as well as using similar techniques to improve the flow down to the foot, so the person was able to avoid amputation. Now, you can find relief from vein symptoms, back to veins now, using techniques similar to the arterial techniques, but without going through surgery. So in arterial disease, we're working to open up the artery. In vein disease, typically we're working on closing down the vessels. And it's because, as I mentioned earlier, the blood is not working, the vessels aren't working properly for you. The blood is going in the wrong direction. Instead of only going up towards your heart, it goes up and down all day long, and that's a problem. So the traditional therapy years and years ago, the surgical therapy, was called a vein stripping. It was sort of barbaric, you know, multiple incisions in the leg, and the surgeon would literally rip out the vein. It was really, really rough. And I think many older doctors don't refer patients for vein care because they recall those surgeries and they associate treatment of vein disease with these old school barbaric surgeries, which are completely unnecessary and really outside the standard of care anymore. And so it's a real issue in terms of re-educating people that there are less invasive treatments to get patients relief from their symptoms. So what's our treatment algorithm? Well, and what are therapies that are available? So there are various therapies that we use here at USA Vein, including endovenous laser treatment, which is using, this has always been the standard of care. It's using basically high energy or high heat to close the vein down. Varicose, sort of a newer treatment that uses proprietary foam. Clarivein, also a catheter-directed device that uses a motor to break down the lining of the vein, as well as injecting sclerotherapy at that time, and ultrasound-guided sclerotherapy, which we use as an adjunct to treat the tributaries. The tributaries, I like to explain to people, are sort of like the branches of the tree. So we use some of these other techniques like EVLT and Clarivein to treat the truncal veins, and then we use Varicose and ultrasound-guided sclerotherapy to treat the tributaries or branches. Here I'm going to show you, play a short video, and basically here you can see it's not exactly right, but here we're numbing the skin theoretically, and then we're making a little incision. That's as small as it gets. Through that incision, we insert a little cannula or a straw that goes into the vein. And then through that vein, we insert the ultrasound probe should go on earlier. Through that vein, we insert the laser fiber, and the vein is actually surrounded with numbing medication prior to pulling it back. And then we pull this vein, the laser wire back, and it ablates the vein. This whole procedure usually lasts about 10 minutes, and it can be done with, and it is done with local anesthesia in an office. You don't have to be put to sleep. It's basically in and out, and it's really a very simple procedure with a tremendous amount of benefit. So as I was mentioning, foam sclerotherapy, that's an adjunct. We use that to treat the little branches that maybe we saw on that last video. And, you know, I love watching this video. I could watch it again and again. But if you look up here in the corner here, you'll see there's a little bright white. This is skin, and this is superficial fat. But here what we see is this is the vein, and you can see that that's foam inside the vein. And, you know, I could watch that all day. It's and you'd see this, and basically when that foam goes in, you know that that vein is going to basically die, and that superficial vein is going to go away. Phlebectomy is a technique I don't use as much anymore because of the other techniques, Varicose and foam sclerotherapy. But when necessary, we can, in fact, map out the superficial veins like this, and using special hooks, pull them out. But again, using the techniques we've used previously, this is becoming less and less, and we're using the minimally invasive therapies more and more. Now, here's a few before and after photos. These are my personal patients. So you can see here on the one side, the gentleman has huge clusters of veins on his upper and inner calf. And you can see, I know the angle isn't exactly right, but you know, I'm a better doctor than a photographer, I guess, but there's a tremendous difference in the way this looks. He had an ablation followed by some sclerotherapy, and you can see the tremendous improvement here. This is another patient who, although again, you could say, well, it's not perfect, but that's not necessarily always the point. The point is you can see there's been a significant reduction in the swelling, the color. You can see this is all purple. Here it's really gone kind of back down to normal, and that's because we've treated both legs with ablation, and the patient's pain and heaviness and discoloration is really dramatically improved. See if there's any questions in the meantime. Don't want to ignore them. In the meantime, there are none, so we'll just keep moving. Here's another before and after photo. Again, these people are like, there's a little gap in the skin. These veins are really bulging. A lot of people complain that in this situation that they can't even put on their shoes, or if they're not careful, they can scratch one of these and they bleed. And when they bleed immensely. So you can see that there's been, the hole is gone here, and that the veins aren't nearly as bulging. I mean, again, the reason I point these out is not to say, look, you know, a lot of people could show, this, and then some magic perfect response. You know, it's not always about that. These person's really symptomatic, and like I said, with a hole in their leg, that shouldn't be there. So when that's fixed, the bulging is better, the pigmentation can improve as well over time, but the person's really dramatically better. You can even see some veins here in the calf, and they've sort of gotten smaller or completely gone away as well. So this is really a very good outcome. So what's the treatment journey like? Well, we see patients typically in initial consultation. Obviously this is a different time we're in right now. So we're able to see people using telemedicine consults, which is, perfectly fine. We used to obviously see people face to face. Usually, eventually the person does need to have a diagnostic ultrasound, which will then allow us to map out which veins are refluxing, because no two people are the same. And so we really have to see whether it's the greater saphenous vein, the lesser saphenous vein, accessory veins, and a whole bunch of other tributaries. We assess the deep venous system to see if there is or ever was a blood clot. All that gets done, and then we basically determine a treatment plan, and we work through that treatment plan. What's important to note is that these procedures are medically necessary. They are not like cosmetic surgery. That's one of the other misconceptions that I really try to educate people about. These are not, there may be a cosmetic component to it. People don't like how they look, but the vast majority of people that I've interacted with, their main goal is to feel better. And yes, if there's a cosmetic improvement, that's a bonus, but they really are looking for symptomatic improvement. And because it is a real medical disease, these procedures are medically necessary and they're covered by your insurance company. So this is not something you have to think about in that situation. They're just like any other disease, whether it's arterial disease or other diseases of the body, heart disease. This is a disease and deserves to be treated as such. So once the treatments are done, we do follow-up visits, and eventually we graduate you to healthy legs.